Hey, welcome everybody. It's the Austin Travis County EMS System Office of the Chief Medical Officer official podcast. I'm your host, Dr. J.R. Pickett, and today I'm just going to do a real quick review of our clinical operating guidelines with regards to carbon monoxide poisoning. We have a cold front coming through here. It's going to be pretty cold, and unfortunately, as many Texas homes are not really adequately insulated against cold and don't have great heating in them, then folks turn to other more high-risk means of heating their homes, including bringing their charcoal grills inside and using generators that aren't adequately ventilated. With these events, we tend to get large numbers of carbon monoxide exposures, usually multiples of patients when this occurs, as you have families that are cohabitating together or sheltering together during the cold weather. So I just wanted to touch on carbon monoxide. So carbon monoxide is odorless, tasteless, undetectable by a human nose, and it has a very strong affinity for hemoglobin, one that is much stronger than an oxygen, and therefore when somebody is poisoned with carbon monoxide, the carbon monoxide replaces the oxygen on the hemoglobin. The hemoglobin can't carry oxygen to the tissues, and then the person ends up oxygen starved, even though they may be in an environment that has plenty of inhaled oxygen in it. Symptoms of carbon monoxide poisoning include headache, nausea, vomiting, dizziness, syncope, altered mental status, stroke-like symptoms, focal neurologic complaints, sometimes chest pains and shortness of breath can occur if the person is oxygen starved in tissues where they have maybe a history of pulmonary disease, maybe a history of cardiovascular disease. So these symptoms, of course, the differential for those symptoms is very, very broad. There are a few people, however, that are particularly high risk when it comes to carbon monoxide. Women who are pregnant, because fetal hemoglobin has a much stronger affinity for carbon monoxide than adult hemoglobin does. So even though the mom may be doing okay from the perspective of their carbon monoxide poisoning, the baby is not. And so that makes this group particularly high risk. People with cardiac history include tachydysrhythmias or other dysrhythmias, and maybe they don't have an AICD or a pacemaker that has been placed. Patients who've had previous MI or congestive heart failure, or if they have lung disease like COPD or pulmonary fibrosis, things that make them much more oxygen sensitive or oxygen deprivation sensitive. Those are high-risk folks. There are high-risk symptoms when it comes to carbon monoxide poisoning as well. Any kind of neurologic symptoms, such as weakness, whether that's global or that's focal, on if it's one side or if it's just one arm or if it's the whole body, it don't matter. It's still a high-risk symptom. Paresthesias, numbness and tingling, that sort of thing. Those are high-risk symptoms. Chest pain, shortness of breath, those are high risk also. Also, any altered mental status, and that includes folks who have emotional changes when they aren't quite acting right according to family, then we do consider that to be a neurologic injury, and that's a high-risk criteria for exposure to carbon monoxide. So what do we do in these situations? So our old clinical guideline used to say if it's the CO level is greater than 5%, then we're going to transport them. That's not really feasible in a cold weather emergency, nor is that really necessary as far as the experts, what they say for treatment of this disease. So first step is to get a good detailed examination. This includes a detailed neurologic exam. Ask about those high-risk symptoms like paresthesias and numbness and weakness, and really test all of the extremities, test their cranial nerves, all of that. Get a good detailed exam. Second, make sure that you get a carbon monoxide level, so a co-oximetry reading. Now on our Zols, we can get that number appears just below the pulse oximetry. So when you plug it in, plug in the pulse oximeter, and if it's got the red flexible part on the cable, then that means that it is compatible with the CO detector. And so you clean the finger, you put the probe on there, and then you cover the probe with something. Cover it with something other than your hand. Okay, cover a blanket or something like that. Protect it from ambient light. Now it may take up to 40 seconds after the pulse ox reads to get the carbon monoxide level. Now a normal pulse ox, unfortunately, the normal pulse oxes just read if the oxygen is saturated with something. It doesn't specify, is it saturated with oxygen? Is it saturated with carbon monoxide? Is it methemoglobin? It just says that the hemoglobin is saturated with something. So you need that CO detector to tell you if it is carbon monoxide, because you could be reading 100% SpO2, but in fact, they're mostly saturated with carbon monoxide. The patient's in real trouble and needs treatment. We risk stratify these patients. Number one is if they have priority symptoms, so neurologic symptoms, altered mental status, cardiac symptoms, then we're putting them on oxygen, but they're going to have to be transported because it is likely that they are going to have to go to hyperbaric chamber for hyperbaric oxygen therapy. So if they've got high-risk symptoms, right there, your decision's made. Patient's got to be transported. If they don't have any of those high-risk symptoms or those high-risk factors, then we can use their carbon monoxide level to help to stratify what we do for these patients. Now, if the patient has a carbon monoxide level greater than 25%, then they should be transported. This is somebody that we may end up putting in the hyperbaric chamber regardless. So even if they have relatively minor symptoms, then we don't want them to necessarily refuse transport and stay at home. So we're going to put them on oxygen. We're going to transport them to the hospital, make a decision there as far as diving them is concerned, even if they don't have those priority symptoms. If their carbon monoxide level is below 25%, then we can treat on site if they don't have priority symptoms. Put them on high flow oxygen and continue to measure their CO level. And then once their symptoms disappear and their CO level drops below 15%, then you can go ahead and consider getting a refusal or terminating your care at that point and releasing them back to the wild. Hopefully the fire department has helped to deal with whatever was creating the carbon monoxide and ventilated the home so that they can safely return back home. So if they're looking good, you get their carbon monoxide level below 15% and their symptoms have gone away, they've totally resolved, then we can release them to the wild. If their CO level is below 15%, 15%, and they have no symptoms, then we're done. Like, we don't have to do anything. No treatment, no transport is warranted. You can go ahead and cut them loose at that point. So above 25%, transport. 25% below with symptoms, then treat with high flow oxygen until the symptoms go away and that carbon monoxide levels drops below 15%. If they are below 15% with no symptoms, we're done. We don't have to do anything else. And if they're pregnant, they've got a significant heart history, significant lung history, any neurologic symptoms, any high priority symptoms like that, then we transport. Now, here's the tricky thing. In Austin, we do not have any hyperbaric chamber. If somebody has to go to hyperbarics on an emergent basis for something like carbon monoxide poisoning or a dive injury, then they have to be transported to San Antonio. University Hospital and BAMC are the ones in San Antonio that have that capability. And we may consider, if you have a person who is severely ill, they're comatose, they're significantly altered, they're hemodynamically unstable, they've got stroke-like symptoms, those kinds of things in the setting of carbon monoxide poisoning, then consider calling Starflight and flying them directly from the scene to San Antonio for hyperbaric treatment. Locally, we don't have the ability to do that hyperbaric, and so if that's what they really need, then there's probably not a whole lot of point of bringing them to a local hospital if we know that we're going to have to fly them south. Again, if they are seriously ill, hemodynamically unstable, comatose, significantly altered, stroke-like symptoms, or just really symptomatic and pregnant, that kind of thing, consider calling a helicopter and getting them directly from the scene to hyperbarics. Certainly, online medical control, we are always here to help as necessary. Give us a call anytime, and we can help to kind of work out those solutions as well. Lastly, I want to talk a little bit about cold weather injuries. Of course, hypothermia is a significant danger to our folks out here. Once your body temperature drops below 86 degrees, then your enzymes and various active proteins in the body don't work very well. So we want to warm them up. If you have a person who's environmentally very cold, then we got to warm them up, and they're not dead until they're warm and dead. So if they don't have a pulse, then get them warm before you consider termination of resuscitation. The question always comes up, what about cold water immersion? So in our system, the water's got to be below 50 degrees before it's really a big concern as far as cold water immersion goes. Then we're going to do a prolonged resuscitation. We may consider transport for perhaps ECMO capability. Currently, Seton, Maine and St. David's Heart Hospital and Dell Children's have ECMO capabilities. So this is somebody that if they're that cold, we may put them on ECMO, and that'll help to warm them up and circulate the oxygen. So we don't really want to terminate resuscitation on somebody who's that cold in the field. If they're frozen, then yes, we're not going to do resuscitation on somebody that is frozen. So if you have to, get a water temperature. Use the thermal imaging camera, get a water temp, figure out what that is. So if they were found floating in the water and the water temperature is 70 degrees, that's not a cold water immersion. That's a drowning. So we treat it like we do our regular drownings. We resuscitate to the best of our ability on scene. If we can't resuscitate them, we terminate resuscitation on scene. But if it's cold water, then consider taking them to an ECMO center with resuscitation ongoing so that they can start that. That is all I have for you for today. Again, just a quick video to go over these things. If you've got questions, we're always here for you. Happy holidays. Stay warm out there. We'll see you later.